All right, I think we'll get going here. First of all, I'd like to thank everybody for joining today. Today's lecture is going to be about reverse stapendotomy. A few weeks ago, we had the pleasure of Jeremy LeVay from London speak to us on stapendotomy. However, he was fortunate enough to have a laser. And I guess my point today is to say that this surgery can be done without laser. Traditionally, in the 1950s, when this surgery was initially, hold on a minute, when this surgery was initially invented, the procedure could not be done or was not done with a laser. Just a second, I've got to admit some people here. So today's lecture is going to be talking about how this procedure can be done using a drill, okay, or how you can do this procedure using nothing more than simple instruments. So there's a lot of topics to talk about when it comes to stapes surgery. We can talk about the pathology. You could spend a day talking about otosclerosis, how it affects the cochlea, the foot plate. We could talk about anesthesia, how to administer anesthesia for stapes surgery. We can talk about prosthesis, the different types, the different metals, the different shapes. We could talk about anatomic variations that complicate our surgery. And we could also talk about complications that make it difficult for us to perform surgery. And that sometimes when you have a prolapsed facial nerve that's completely obstructing the oval window, you can't even do the procedure. We could talk about revision surgery, and we could talk about just the pearls of surgery. But the most important thing is to realize that there's a lot of different topics to talk about with regards to otosclerosis. The most important thing is to realize, what is our ultimate goal here? You know, what is the goal of the surgery? The goal is to remove the fixed stapes, place a piston, and safely close the air-bone gap. It seems pretty simple, but in reality, it is a complex process. There's a lot of different stages of this procedure. As you can see, I've kind of outlined them. And most importantly, I've highlighted in yellow the area that we're going to talk about in terms of what is a reverse stapendotomy. And simply put, it's removing the superstructure after you place the piston. Traditionally, the surgery was designed so that the superstructure was removed, then the piston was placed. And from a historical perspective, and I think it's an important thing to understand the history of otosclerosis and the history of ear surgery, and that is that in the 20s, there was a Swedish doctor named Holmgren who pretty much started doing early fenestration surgery, followed by Sordel from France. And then in the United States, Julius Lempert in the late 30s did the one-stage fenestration procedure via an endoral incision. And during that time period, there were other people like Sam Rosen, also from New York, who was interested in mobilizing the stapes because he felt that you could prevent doing surgery by just mobilization. So what he did, he went into the morgue of many hospitals in the New York City area, and he dissected out stapes. And he became very proficient at it. He designed his own instruments called the Rosen needle, which we frequently use. In some countries, it's under a different name, however. And I kind of am the proud owner, if you can see here. These were the spectacles that Sam Rosen used when he did his mobilization procedures and he did his work in the cadaver lab. These were given to me by my professor, Dr. Lawson. Sam Rosen was on faculty at Mount Sinai Hospital in New York City, and these were given to the hospital by his widow. So the interesting thing is, and after Lempert, Rosen, Shea in the 1956 did the first stapes surgery procedure in the United States. And since then, it's been modified, improved upon, and we have multiple methods by which we can do it today: laser, drill, or just simple instruments. Before you operate on a patient, probably the most important thing to do is to confirm your audiogram. And to do that, you're going to need to use tuning forks. All right. Tuning forks will be able to help you differentiate a conductive versus a central neural hearing loss. In some countries, there are patients who do not have the pleasure of having a trained audiologist, and those patients with central neural hearing loss who are not masked can present with what appears to be a conductive hearing loss when indeed it isn't. And if we operate on those patients without doing tuning fork tests, we're going to find that we're going to be operating on patients who don't have any pathology. So it's really important here to do tuning fork tests. Anesthesia. Most people who have good experience with local anesthesia, as long as the patient's willing to take it. My personal experience is that I essentially will not do a stapes surgery under general anesthesia because I want to monitor the vestibular function. I want to see if my piston is too long and is causing vertiginous symptoms in the patient. This you cannot evaluate when a patient is under general anesthesia. Am I concerned that they're going to hear? They're going to hear when you do a fenestration, okay? Unless you destroy the structures of the vestibule or have a traumatic complication. So to ask a patient under anesthesia, can you hear? The bottom line is they're going to be able to hear you. So the vestibular aspect of their vestibular aspect of the patient is much more important rather than can they hear. And what I like to do is I like to give them usually about 5 of morphine, which is equivalent to about 75 of Demerol, or about 100 micrograms of fentanyl intravenously, and then either midazolam or Valium, and then give them some local, and I usually give them about anywhere from, and all these injections are in the canal, and you'll see those in a few minutes, usually less than a cc. And I'll also inject the tragus, and I'll use about 1 to about 30,000. I'll use my lidocaine and epinephrine, I'll mix them together. Anybody who needs to know more about this, I'll be glad to share that with you. And then in the operating room, basically, I usually have the nurse sit on the other side of me, and I keep the anesthesiologist as far away as possible because they do nothing more than interfere. So the injection is pretty critical. You need to make sure that the bevel of the needle is down like this and not up. If you inject in this manner, you'll have a tendency to tear the skin of the ear canal, which makes it bleed and makes it more difficult for reconstruction and replacement of your flaps at the end of the procedure. More about around near 12 o'clock, near the in the canal, the skin gets a lot thicker here. It's thin here. So the injection is usually just at the point where the hair in the ear canal terminates and the skin becomes one simple layer over the bone here. You got to be careful not to over-inject superiorly, because if you do over-inject superiorly, you can get blistering and it will thin out the skin so that when you lay your flap down, you'll have troubles. So here we have a injection. All right, this is a right ear, and you can see I'm injecting right at the end of the ear canal where the hair follicles stop. And the injection here it takes a lot of pressure, but you do it under a controlled fashion, and you wait for the blanching to occur, which you can see the skin of the ear canal going down to the drum blanching. And I usually do that one injection there and one injection more superiorly. And that's it. That's it. And then I'll inject the tragus only for one reason. In case I need to take a piece of perichondrium because I could have torn the flap. At sometimes I'll inject also the great auricular nerve, the auricular temporal nerve, which is a branch of the trigeminal, which innervates the tragus and the anterior canal wall. So let's go to the procedure now. The most important thing is to make sure that you're visualizing the anatomy of the area. And what you need to be able to see is you need to see the horizontal facial nerve. You need to be able to see the pyramidal eminence. You need to be able to see the round window and the malleus. These are the four important structures which you need to be able to visualize when you are doing stapes surgery. Another important thing is magnification of the microscope. Here we have 0.6, 1, and 1.6. You multiply these times 10 or 12.5, depending upon what your eyepiece magnification is. But most importantly is you do not want to be over magnified or under magnified. You got to find that happy medium. And I find that 1 times power on the microscope and 10 times power on the objective, which will give me a 10 times magnification, is adequate enough for me to essentially do the whole surgery. That gives me a good perspective of the surrounding structures. And if there's any reason to address a higher power, like 1.6 or 2.5, I will do that when needed. And that mostly comes under circumstances where you might have to extract some of the foot plate with a little foot plate elevator, or you need to see a structure that you couldn't see under a lower magnification. But for all intents and purposes, a good view of the ear with the surrounding structures is what you're looking for, and avoid over magnification. All right, we mark out our incision, our tympanomeatal flap, and again, you can't make it too short. 5 millimeters, even maybe up to 7 is adequate, because when you remove the bone, should you have a short flap, this area will collapse in. You can get possibly a formation of cholesteatoma, but most importantly, you need to have an adequate flap developed here. You got to stay on top of the bone. Critical. If you start getting off the bone, which I'll show you in just a second, you're going to get into complications. Making my flap, not a problem. Staying on the bone. When you come up superiorly, you're going to wind up, and I use this most of the time, a Bellucci scissor to cut here, because the skin is a lot thicker here, superiorly. Elevating it, staying on the bone, not working in the soft tissue, but staying on the bone and pushing down gingerly, not working in a hole, and coming down to the annular ligament. which you'll see if you're paying attention. And this is what I mean by being in the wrong plane. If you're in the wrong plane here, you're going to wind up, here's your round knife, or number one, you're going to wind up having a space between your instrument and the bone, and you could possibly create a perforation. This is the method here. When you stay with your round knife right on the bone so that you come down to the annular ligament. This will prevent you from creating a perforation. And this applies to all surgery. This applies to all the surgery you're going to do. When you're doing a tympanoplasty, a simple tympanotomy, the same principles apply. Now you come down to your annular ligament, which is right here. You can use a Rosen pick, and you'll enter the middle ear space, doing this carefully. Again, you do not want to create a false plane. Creating a false plane creates a perforation. You take your annulus elevator, you work it from superiorly to inferiorly. And should you have any bleeding, always using a little adrenaline with cotton will help control the bleeding. Remember, in stapes surgery, bleeding is your enemy. So you have to be very, very careful, and you have to control the bleeding. Lift your flap up, tympanomeatal flap up. This is a right ear. Try to get it as far anteriorly as possible. You're going to have to remove and come more superiorly to do this in this case. And your goal here is to go as far anteriorly as the notch of Rivenus, if possible, which is basically the neck of the malleus. No further anterior do you need to go. Chorda tympani, it's critical that you try to move the chorda tympani inferiorly without stretching it or injuring it too much. The more injury you have to your chorda tympani, the greater the chance that patients are going to have dysgeusia or metallic taste. And if you can preserve it, that is the most important thing, because if the patient especially has bilateral otosclerosis, you do not want that patient to have, you do not want to sacrifice both the chorda tympani. The patient has a potential to have, the dysgeusia for a long time. So here's what we've got. We've elevated our tympanomeatal flap. We're looking at our round window, facial nerve, foot plate, but we still need to remove this area, the scutum. And we use a nice curette, sharp curette, right at the edge here of the bone. And we go, and as we do this, it's a lot of force in the wrist, and it's a lot of pressure on the bone. And we kind of pick it out slowly. Now, if you do find the notch of Rivenus and it's well developed, you can put your curette right on the notch of Rivenus, and it will help guide you to take this out. But one of the most important things is to not flip your curette in a fashion which takes you towards the malleus. Because you're using so much pressure, there's a potential that this instrument could slip and you could dislocate the incus or the malleus. I've seen it done before. Therefore, your curetting is always posteriorly in this direction and not in the other direction. Once you've got that you've curetted the scutum, you should be able to see pyramidal eminence, much better view of the foot plate, and you're ready to do your surgery. Palpation of the ossicular chain is critical because there can be other pathologies that can mimic otosclerosis. You could have a bony bridge. You could have a bony bridge that's going from the malleus head to the epitympanum. You could have tympanosclerosis. You could have a third window with dehiscence of superior semicircular canal. All those possibilities exist. That's why palpation and confirmation of fixation of the stapes superstructure is of ultimate importance, irrespective of whatever the audiogram shows. So if the audiogram shows a conductive hearing loss, but you've got complete mobilization of the superstructure, as well as the malleus and the incus, you need to consider another pathology, like superior canal dehiscence. At this point, if you do have a mobile stapes and the rest of the ossicular chain is mobile, go to high power magnification. Go to 1.6 or 2.5. Move the stapes and see movement of the annular ligament. That will give you confirmation that you do not have otosclerosis. Measurements, I always do my measurements before I remove my superstructure. Some people do not. And I measure from the lateral aspect of the incus to the foot plate. You'll have to learn your own method, okay? Some people measure from underneath the incus to the foot plate. Either method is fine, but you have to remember, we have to take into consideration the thickness of the foot plate and the thickness of the incus. So when I do this procedure, measuring lateral to the incus to the foot plate, my normal pistons usually measure between 4 and 4.5. So if I measured, and the measurement with this instrument will show me 4 to 4.5. If I go underneath the incus to the foot plate, it's going to measure 3.5, and I'll have to add a 0.5 millimeter, which will bring me to 4. So just make sure you use the same methodology for your measurements at all times so that you don't run into any kind of errors because you measured incorrectly. Once you've done that, I cut the tendon, stapedius tendon, and here's where the reverse stapendotomy concept is coming into effect. Normally, at this point, traditionally, you just down fracture after separating the incudostapedial joint, the superstructure. In a reverse stapendotomy, what we do is we drill the posterior crura, remove it, gives us a visualization. We can now make a nice control hole, which is the same as our stapendotomy. And we'll talk about the advantages and disadvantages of doing it this each way. So what are those advantages or disadvantages? First of all is, if you just do a down fracture, a couple things can happen. Number one, you can avulse or float the foot plate, which means now the whole foot plate is mobile or has been completely removed. If the foot plate becomes mobile, you cannot drill on it. You're going to have to take the whole foot plate out and do a total stapendectomy. So that's number one. Number two is, many times when the superstructure is intact, there is no opportunity to do a control hole. And what is a control hole? It is a small fenestration into the foot plate in the posterior 1/3, okay, which will allow you to do a few things. It's going to be your stapendotomy site. It will allow you to also, if you have a gusher, you can stop there, okay, and it will allow you also to prevent rupture of the membranous labyrinth, the utricle and saccule, which potentially could happen as you down fracture. It's called the hydraulic effect. I've never had anybody talk about it. I've not seen about it, but it's in the literature. With the drilling procedure, when you drill the posterior crura, you got great visualization now. You can do a control hole, which is your stapendotomy, and you're in a great position. You have not down fractured. You have not floated your foot plate. And if you have a gusher, you still have the anterior crura attached, which will allow you, should you have a gusher, to put a piece of fat and and fat, or fascia with fat over it to control the gusher. So I think there's a lot more advantage to doing the reverse stapendotomy. That is the way I do it. Another important thing is once you've got your control hole open or your stapendotomy, it's really important, should you have any bleeding, never to suction through your stapendotomy, but suction around the area. I will, if I do not have a stapendotomy performed yet and I have bleeding, what I'll do is I'll inject lidocaine and epinephrine that I've used for my canal injection in the middle ear space. And I'll leave it there for 2 or 3 minutes. If I do have an open stapendotomy site, I'll take a small piece of cotton and put it down here. I do not want lidocaine and epinephrine to get into the vestibule itself if I can prevent it. Again, looking at the piston, we could sit here and talk about various types of pistons. They all have similar anatomy, as one might say. They have the penetrating piston part, which is usually anywhere from 0.4 to 0.6 or to 0.8 millimeters in diameter. It's not been proven that larger pistons in terms of the diameter are better than smaller ones. The normal sized ones that people use are about 0.6. If you've got a whole array of pistons, you can use larger pistons. If you've got a large opening in your foot plate, let's say you have to remove some of a fractured foot plate and you have a large opening, but not enough to do a total stapendectomy, you could use a 0.8. If you have a very small area, a small niche, because of a prolapsed facial nerve, you might use a 0.4. But generally speaking, I can't remember when I've not used a 0.6. We have the shaft, and then we have our loop. Now, one of the things is that most people find really difficult, aside from curating the scutum, is to put the piston in. And I think if you look at books like Mario Sana, it's really important to grab the piston at about a 145-degree angle here. And these are not good examples, because this angle will give you a view of the foot plate with the fenestration and also allow you to put the loop over the incus. So if you can do this and grab the stapes piston in the proper fashion, you'll have a good view and you should be able to put the piston in the fenestration and put the wire loop over the incus in one move. And here we have it. Again, it's been put on, and then we can use a little groove director, which is this instrument, to manipulate the loop on the incus, and then we will crimp it. There's some, and here we have crimping. There's special instruments for crimping. If you don't have a special instrument, you're gonna use an alligator, and you have to be really careful so you do not over crimp. There's small blood vessels that go to the distal portion of the incus, and if you over crimp here, you will compromise the blood supply here, and you will eventually get necrosis. And a year or two after surgery, the patient's going to come back with another conductive hearing loss because there is incus necrosis from over crimping. So there's a real art to crimping. I crimp and I always make sure that it's firm, but that I have mobility of my prosthesis in the up and down direction, and that it's not fixed to the incus. There's other prostheses. It's called nitinol, where you use you can use a laser, and it self crimps for you. But again, here you need the laser to do that. The next thing that's really important is that once your piston's in, you need to check the movement, both horizontally and vertically. Really important because your piston could be too short. Again, by movement of the malleus and the incus, you can check to see if the piston stays within the fenestration. It should if you've done the proper measurement. And you can do a horizontal movement and to see if it flips out. Score a little blood off of the promontory with the Rosen pick, and you close your fenestration. So let's go back now and spend a little more time on the reverse stapendotomy. Again, we have our superstructure, anterior fenestra disease, otosclerotic plaque here. In children who have congenital otosclerosis, their otosclerotic plaque can be anywhere posteriorly, but generally speaking, patients who do not have congenital otosclerosis or a obliterative foot plate, an obliterative foot plate is where there's otosclerosis all around, will have isolated disease to the anterior fenestra, which is here. So we've got our disease, we cut the tendon, we laser or we drill the posterior crura. It gives us great visualization here. We put our fenestration in, we put our piston in. Once the piston's in, we cut the incudostapedial joint, we remove the anterior crura. Okay. So again, this is a great technique. It prevents foot plate mobilization or avulsion, and it allows us to not have to perform stapendectomy. Is it bad to perform a stapendectomy? Absolutely not. There are well-known otologists in this world that continue to do stapendectomy, even with the advancements in the procedure to doing stapendotomy. So this is a little chart I put together, conventional, which is a down fracture, and the reverse stapendotomy. All right. We do the same procedure, although here we cut the tendon first, we down fracture, and then we fenestrate. Here we cut the tendon, take the posterior crura down, and then we fenestrate. Again, superstructure is removed in conventional approach first rather than at the end in the reverse stapendotomy. Floating foot plate, much more frequent with conventional stapes surgery and it's very rare with reverse stapendotomy. A gusher, I think you have much better control of this and with the reverse procedure because you still have your anterior crura and you're able to have an adequate amount of pressure over the fenestration in the foot plate. Incus support, much better, and your control hole. Again, control holes are difficult in many patients because the posterior crura obstructs the visualization of the foot plate. When you do a fenestration, not only you're doing a control hole, okay, but you've got a great view because that posterior crura has already been removed. So let's look at some live surgery. All right, I had to get this off the internet because I don't do down fracture and I don't do conventional stapes surgery anymore. All right, so this looks like a right ear to me. You're touching the malleus, cutting the stapedius tendon, separating the incudostapedial joint, and then boom, down fractured. Everything came out, even the stapes foot plate. All right, and now you see the measurement rod to take the measurements, which I wouldn't do now. I would have done it beforehand in the natural state. You know, you might over measure when you've removed your superstructure because the position of the incus could have now moved because of the tension on the ossicular chain by the malleus. So I think it's really important to measure beforehand. And again, in reverse stapendotomy, it's easy to measure because you've taken your posterior crura out. Just as it's difficult to make a control hole when your posterior crura is in position, it's difficult many times also to make the measurement. So here's a video. This is the reverse stapendotomy. Again, this is my surgery. I like to make the horizontal, or excuse me, the first incision parallel to the canal. I'll come out about 6 millimeters, and I'll start making my second incision, which goes all the way up to the malleus, short process of malleus. Staying on the bone here, again, critical so you do not get in the wrong plane. And as you come more superiorly, the tissue gets thicker. You're going to use a little Bellucci scissor to separate and cut. Again, very important, stay in the right plane. Cutting with the Bellucci scissor. You've got to get that exposure superiorly here. All right, this is a right ear. I use a little cotton with adrenaline, and I'm going to find my annular ligament, which is right there, staying on the bone. And then I'll come to a very thin membrane underneath my annular ligament, which is going to be the mucosa of the middle ear. Annulus elevator, got underneath that. I'll use the annulus elevator like a round knife as well to lift up the flap. Many people limit the elevation here and it makes it difficult for them. So good exposure from the notch of rivinus inferiorly. Now I'm taking down my scutum. I'm curetting it. And as soon as I finish curetting and I have proper visualization of the facial nerve, stapedius tendon, foot plate, and the round window, I'll be able to assess the mobility of the articular chain and confirm the diagnosis of otosclerosis. I like cotton and adrenaline again because it allows me to keep the bleeding down and it removes little bone fragments. Okay, there's my chorda. You got to be really careful about preserving your chorda at all risk. Don't stretch it too much and bring it down. Now, sometimes you find these little adhesions. And now I'm going to palpate my articular chain. I'm palpating the stapes, the incus, and the malleus to confirm the diagnosis that it's otosclerosis. And this only comes with experience to feel what a fixed stapes is like. I have a measuring rod that has like 3 stairs on it. I made my measurement. I'll cut my tendon. I'll come in with my drill and I'm using a 0.7 millimeter diamond, and I'll drill that posterior crura out. Right now, I'm just removing some of the posterior crura. I've not disarticulated my joint. My anterior crura and my joint are all intact. And now I've got a good visualization of the foot plate. I'm doing a fenestration, again with the 0.7 millimeter diamond. You can practice this on an egg, a regular egg, trying to go through the shell, which is a lot thicker than the foot plate. And again, I'm using suction now, suction just to get the whole area clear, but I'm not suctioning the fenestration, all right? Now, I only have 4.5 millimeter pistons. So if I need a smaller piston, I have a special block here. I'll cut my pistons, which are made out of titanium, down to the appropriate size. I think only once in my life have I used a larger piston than 4.5. Majority of patients are about 4.5 to 425. And here I go, putting my piston in. It's angled correctly at 145 degrees. I let it go because it's in the fenestration. And with a little help of a groove director, I put it on the malleus, or excuse me, the incus. I'm going to crimp it. And again, there's all kinds of types of crimpers. Alligator can be used as well, but do not over crimp. Okay. Now I'm separating my incudostapedial joint. I separate the joint. My anterior crura should be able to be removed now. I can down fracture it. And then I'll use the alligator and I'll remove the anterior crura with the neck of the malleus. I'm going to use my Rosen pick here, score the promontory, and it's going to bleed. And I'm going to get blood here, which is going to overlay my oval window. It's going to close the fenestra, the fistula, excuse me. And with the patient in a operated ear towards the ceiling for 2 hours, the blood will coagulate and the fistula will be closed. I'll put my tympanomeatal flap back into position and I'm done. So what are the advantages of doing a reverse stapedotomy? First, you got a control hole, and if you did have a footing of, you got a control hole. Let's just leave it there. Okay. Also, it's easier to control a gusher should you have one, as I stated before, because your anterior crura is still intact. And then it also prevents the hydraulic effect if you have to do a stapendotomy. And you have less chance of creating a floating foot plate. So what are the challenges? The challenges in stapes surgery, irrespective of how you remove the foot plate, are pretty much the same. You have to know how to deal with a narrow canal. And it's going to be really almost impossible to do any surgery, be it endoscopic, and I don't do endoscopic stapes surgery. It's going to be very difficult for you to operate in a canal that's less than 4 millimeters wide. Also, creating perforations by being in the wrong plane, and not staying on top of the bone, you will create a perforation. You've got to rule out other pathologies by checking the ossicular chain for movement. You've got to prevent necrosis of the incus by not over crimping. You've got to know how to deal with abnormal pathology, such as facial nerve prolapse, and how to deal with that. We could spend an hour talking about that. What if you have a overhanging promontory? How do you deal with that in that situation? What do you do when you have obliterative otosclerosis? What do you do when you have a floating foot plate? How do you control excessive bleeding? What do you do if you have a stapedial artery remnant? What do you do with a gusher? And most importantly here is that in patients who have a history of endolymphatic hydropneus, I do not recommend doing surgery on these patients. Their uteral and saccule will be dilated, and there's the chance that you're going to wind up getting that piston to hit the uterosacral, and these patients are going to be dizzy. There are some people who say if the patient's asymptomatic for a year, that you can do surgery on them. Well, the question is, I don't think that really works well, because if the patient was asymptomatic for 30 years and then developed Meniere's disease, what's to say they're not going to have further episodes, even though you're controlling them with medication? This chart just shows you a little comparison between stapendotomy and stapendotomy in terms of air bone gap closure. It is essentially the same, especially in the hands of very experienced middle ear surgeons. you're not going to find that one procedure is really going to give you that much more benefit than the other. Well, that's pretty much it for my lecture today. I'm really a proponent of the reverse stapendotomy. I'm not dealing with floating foot plates anymore. I'm not having to do total stapendectomy. And I just think it's a much better procedure. Now, there is an instrument that, if you do not have a drill, it's called a Crura scissor. It looks like a curved alligator, and it's basically, or a micro Bellucci scissor that's curved, but you can cut the posterior crura instead of drilling it. And now you've got your posterior crura removed. You can use, if you don't have a drill, you can use a hand drill or a micro perforator, and you can take and create your fenestration. The only time where you're not going to be able to do this surgery is in a patient with obliterative otosclerosis, where the whole foot plate is obliterated. You're going to need either a drill or a laser, because you're not going to be able to do it by using a foot plate perforator. And if you're going to use a hand drill, you're going to probably be there for quite a while. All right. So again, that's my lecture for today. Does anybody have any questions? If they do, please either raise your hand or unmute yourself, and I'll be glad to answer them for you. If not, we can call it a day.
Lovera wrote in the chat at the chat, Richard.
I'm sorry, I said there's chat. Okay, thank you. Okay, so this is from Oscar. He says, hello, everybody. Okay, Lovera, Richard, question. In which cases do you use perichondrium? Okay, here's the situation. If I'm doing surgery and I'm drilling the foot plate and the foot plate cracks, don't forget, the drill is only an instrument. You're not able to, sometimes you're going to put that drill there and your foot plate's going to fracture. Okay, if I have greater than 50% loss of the bony foot plate, I will use perichondrium to cover the foot plate. If I do not have more than 50% of the foot plate removed, I will close that with blood. All right? That's just the way I do it. I mean, I've heard from a historical perspective that when they first started doing stapes surgery, they did a few things which are kind of like taboo today. They would suction all the perilymph out of the vestibule, which would cause patients to be dizzy for days. Because the only time I find my patients dizzy postoperatively is if for some reason I suction perilymph. Otherwise, 98% of the patients are not vertiginous in recovery room. And Nega can talk about that because he takes care of most of my patients, okay? So number one, okay. Number two, they would do total stapendectomy and they wouldn't even put blood there. They'd put the piston in. To me, that's ludicrous because you've got to close your fenestration, be it with fascia or blood. So to answer the question, again, if I have more than 50% of my foot plate gone, I will use perichondrium. I have used vein graft in the past, but perichondrium's easy. I have also used biodesign, which is an artificial substance. It's not been approved for foot plate closure. It's been approved for tympanic membrane perforation closure, and it's used in neurosurgery as well. But we've got a paper coming out. We've done about 4 patients with it. We've had no complications, and I think it's an alternative. It might be an expensive alternative, but it is an alternative for a grafting material to the oval window. So I hope that answered your question, Lovera. If not, send me another question. Okay. Where's the best place on the foot plates to make? Well, if you know your anatomy, Oscar, there's what's called the utricle and the saccule, all right? And you want to make your fenestration in the posterior third of the foot plate, all right? Because your penetration of the piston is going to be about 0.25 millimeters into the vestibule, and you do not want it to hit the utricle. If it hits the utricle, you're going to be dizzy. And the saccule is much closer to the foot plate. In the vestibule, the saccule is higher up, and there's not as much space between the foot plate and the saccule as there is the foot plate and the utricle. So posteriorly is the posterior 1/3 is where we put our piston in. All right. Anybody else have any questions today? There's a lot of good books out there. There's a lot of good videos on the internet. Stapes surgery is different from most other ear surgery because it takes a lot of skill, a lot of patience, and a lot of experience. And the other thing is this: it's stapes surgery is cosmetic surgery of the ear. I say it's cosmetic because you can put a hearing aid on the patient; they'll do just fine. Many patients don't want to use it, and therefore they elect surgery. But I will say one thing: in an inexperienced person who's not doing at least 20 of these cases a year, it might be better to do and offer the patient either a hearing aid or refer them to somebody who's doing a lot more of these surgery. Because the way to prevent complications in stapes surgery is to have lots of experience. 1% of people who have stapes surgery will go deaf. And the deafness comes because of bad judgment on the patient and with respect to the surgeon and what he's doing, and lack of experience. That is probably the number one reason people go deaf. There are other reasons which, even when you do the surgery perfect, you cannot tell what the etiology was, but it happens. But again, the experience of the surgeon is of utmost to prevent any kind of permanent deafness. All right. So I hope that helps you. Mario Sana's book, which is Surgery of the Middle Ear and Mastoid, has a chapter on stapes surgery. It's really good. It's very basic. And then there's other books that are out there just dedicated to stapes surgery itself. So if there's no further questions, thank you, everybody. We'll send you some updates on the WhatsApp platform as to the upcoming lectures, okay? Thank you and have a good weekend, everybody.